Michel Maziad, I think, is going to present. I got that right, Michel? Thank you very much.
So I want to thank the Beck Foundation and CIHR for giving us the...
Can we get your attention? Sorry, everybody. So we can crack on. Finish today. Thank you very much. Sorry, Michel.
So I was saying that first I want to thank the Beck Foundation and CIHR for giving us and giving our group the opportunity of this meeting. In the few minutes that I have, I will try to concentrate on 2-3 ideas that we had and that we have started to implement. The question that is behind the meeting is how come that with good professionals, good service deliveries in the primary care and good secondary service experts, how come that many things are stalled, blocked? And transformation to us in our group, because we have in the Quebec City region started a system, and we have a system strategy. And as an old psychiatrist, I'm now 64, so I heard many things. And repetitions and same sentences and paragraphs. I'm probably the oldest child adolescent psychiatrist in the room, maybe psychiatrist. And, but I'm still having my CIHR grants and my Canada Research Chair, so I'm still alive. Can speak 4 more minutes. What we hypothesize that we have to address at the system level at the same time, simultaneously, these 5 systemic barriers. We believe that if we address only 2 or 3, there will be no change. So with the good talks we have listened from the colleagues today, you talked about these barriers. The administrative barrier of 18 years, the difficulty of the primary care professionals to have access to the secondary care experts, non-optimal knowledge transfer, and those terrible ruptures, discontinuity between the main care provider and the patient and families. Every 3 months, every 4 months, there is a change. We know all that it's terrible. We can do nothing about that because this is a systemic problem with unions, with the institutions, with the laws, etc. And the silos of diagnosis, where all of us know that in adolescence, in young and late adolescence, depression, bipolar disorder, schizophrenia, drug abuse with weird behaviors, schizophrenia, they look all the same. The symptoms are the same, the presentation, and you can distinguish the endpoint of the trajectory after 4, 3, 5, 6 years. And in addition to that, the duration of untreated syndromes is terribly long. So we devised a system in the whole region. So the Quebec City region is a nice place to do an experiment, and we are keen to have our group made now of 12 scientists, all younger than I, which is a good thing. And we embarked in the system the 5 institutions. So in Quebec, with the 600,000 in population, we have the CHU, the University Hospitals, General Hospital. We have the Mental Health, University Mental Health Institute, Institut Robert Giffard. We have in the system, as you will read on the poster, the Centre Jeunesse Institut Universitaire for the youth with externalized problems, drug abuse, etc. And we have the 2 primary care institutions in the region, the 2 C3S, who are in charge of. So it's the the head, the CEO of the Agence Régionale is the head of the consortium. We did a consortium to supervise this transformative research, so everybody is in. The board is made of the Dean of the Faculty of Medicine, the head of the Agence Régionale de Santé, and the 5 general directors, the 5 CEOs of these 5 primary care and secondary care hospitals and community health organizations. And we are devising 4 research projects to address simultaneously these 5 systemic problems. And so we hope to be included, adapt and adjust to the Canadian network, share instruments, indicators, and I am done by 30 seconds more than 5 minutes.
Perfect, right? Perfect. Yeah, thank you very much. Michelle, thank you very much. Okay. We now have research, education, and action to defend youth mental health, and that's Meryl Hammond, Daphne Hutt-McLeod, and Enyak Korgak.
Which one? Nakomik Wanita Wundama, thank you. We're going to take turns describing what we want to do. My part will be to explain briefly the team structure. We have come up, with we have 5 TRAM-specific stakeholders plus other stakeholders, which could include elders and other community members that don't fall neatly into the policy, research, and so on category. And we also, from that, we have divided, the inner, middle, and outer levels. The inner level being, this is the sort of the lead team, and then the middle would be the organization, individual engaged in project planning, implementation, evaluation, research. And the outer, will be those individual or groups providing advice and strategic direction. Some stakeholders wanted to take part at different levels. For example, because I work as a government employee, I am what, if you look at the diagram there, 1A, which is like a family member. And by the way, as it says in the one page, I did lose, a daughter, 6 years ago, June 12. And another family member, really close, 2 years ago. So anyway, that my role, and also as a government, a policy advisor or person. We have other members, that I'm not going to name because we cut down, the presentation to make more room, for both Daphne and Meryl to explain what we want to do. So I'm not going to go into that. But if you look into the what we have, we have other involved people, from other regions of the in northern Canada.
Hi, as mentioned, my name is Daphne Hutt-McLeod, and I represent Eskazoni First Nation, which is one of the largest communities, First Nations communities east of Quebec. Slightly over 50% of our 4,000 population is under the age of 25. And that's why when you're looking at the presentation, we're proposing that we focus on Inuit and First Nations populations first, and then roll out the program to the rest of Canada. We acknowledge that there's just as many problems outside First Nations and Inuit communities, but we'd like to be able to focus on First Nations and Inuit first. We do favor a strong community-based approach. We are looking at providing services on the ground and working our way up. Our research is designed to be able to meet the needs of youth and families. When you look at our model, we're focusing on prevention and promotion as well in the model that we're doing. And our program is looking at providing services to all youth, not necessarily those that have been divided up into subsets or into key diagnosis areas.
I'm feeling the pressure here. We missed the youth empowerment arrow, but join us at the poster and we'll explain more about that. We see you standing there, Ross. Okay. This is our boring slide, no graphic. Basically, we're looking to reduce stigma and engage the community in detection of cases and referral for care, to empower youth to take greater responsibility for their own mental health, at the same time as saying we're not going to victim blame anybody. We fully understand that people are sick for very good reason, but we feel that there's something within all of us that could be tapped much more than we are doing at the moment in the area of prevention and promotion. So we want to broaden the definition of care to include all support that the community can offer. For example, early identification and referral, ongoing support for youth between mental health appointments and so on. And to provide training, which might be face-to-face or distance education. We use a lot of distance education, especially in the north, where distance is such an issue. And age and culturally appropriate resources for both health workers and youth and family members themselves. And very briefly, this graphic is also on our poster. Those of you who saw Jacques' slide originally on the original TRAM PowerPoint had the first two valleys of death. We've added a third valley, saying that a big problem with research is often that it doesn't make that leap from what's at the level of clinical practice and decision making. It sort of sticks there. We want to take it through to that next level of actual uptake among communities, families, individuals, families, and communities. So we see a big role for this kind of community-based approach to bridge this third valley. Thank you.
Wonderful. Thank you. Thank you very much. We now have Réseau d'intervention de proximité auprès des jeunes, and we have Diane Aubin and Amal Abdelbaki. Thank you very much.
Voilà. So, good afternoon. So we're going to talk to you about a clinical network that we want to propose as an example, a network that we built over the years for homeless youth, the one that have fallen between the gaps. I'm Amal Abdelbaki. I'm a clinical psychiatrist, and I'm also a clinical researcher working at the CHUM, which is a hospital in Montreal, and in a research center.
Hi, I'm very honored to be with you today. I'm Diane Aubin, psychologist, psychotherapist, and clinical consultant at Dans la Rue, an organization that welcomes youth in very precarious situations. Not only youth, adolescent and young adults, but young families. And I was already working at the day center of Dans la Rue when I met Amal more than 10 years ago. In order to, and I told her and her partner at that time, Dr. Granger, in order to treat youth, to do prevention, you need to know them and to meet them in the place where they feel secure, in order to transmit the trust. So they came, Amal came at the day center, and we met, and since we began to build up, to forge links with other partners, le Refuge des Jeunes de Montréal, which is very well known, the clinic, the street youth clinic, CSSS Jeunes Mans, first line primary care, where there's a medical team there, and among others partners, including researchers who've been participating and initiating researchers with us and with the population we meet. Since we have regular proximity meetings with between us and these representatives, and we're going to talk about it today.
Okay, so what is unique and transformational in our solution? First, we've built an outreach intervention program. So our goal is to increase the collaboration of youth by improving accessibility and the diversity of services that are offered to them in a youth-friendly approach. We're reaching out to the most vulnerable in their milieu with a new team that is a psychiatric team that outreach and work closely with and in collaboration with community services. We're ensuring also a regular presence at the moment and where the youth express the need to be helped to work in collaboration with the workers they trust. And we share a philosophy of cooperation and shared responsibility between the institutions like hospitals and communitary organizations, shared philosophy of respect of the characteristic and recognition of everyone's expertise.
This way to work address a major issue, which is the transmission of trust. To work with the youth ambivalence, which is there in adolescents and young adults in transition. And we work with this ambivalence, so the youth is not obliged to demand help in order to have a meeting with us and discuss their situation. And this is a very different attitude. And we work all on in collaboration, cooperation with the worker they trust. Even myself as a psychologist, in my office, youth won't come in my office without an intervenant, a worker they trust. So the pertinence of the accompagnement is very important. Facilitate access to services and treatments by a respectful and non-intimidating approach, which is very important for this heterogeneous population. Intervention in the milieu, flexibility and timing. Easy access to services and continuity. Timing with adolescent and youth is very important. Making sense for youth to increase their collaboration and continuity of our services. Oh, it's me again. Which problem do we want to resolve? By adding professional staff to reach out youth on the street and their milieu. By building up close links with community agencies, workers, and other institutions or organizations concerned with youth, DPJ, youth protection, schools, among others. We have a school at the Day Center with collaboration with the Commission Scolaire de Montréal. By allowing time and space for meetings and discussions, improving professional proximity between medical teams and other workers concerned by the diversity of youth mental health. Proximity meetings, that's the key. By easing the access to services to youth, working with their ambivalence, I've said that before, with the time required for building up trust, taming, apprivoisement, with the support, collaboration, participation of workers during interviews or visits with the doctor or any other social worker.
Can I just say we've had our 5 minutes?
Yeah. So the importance is that for the youth there is a continuity between the services and that they have access to the services they need without having to ask themselves if they're at the right clinic, at the right if they have the right diagnostic, if they have the right group age, if they're at the right stage of their illness. So the challenges are, I think we need to pursue the research work on the impact of such a network, a clinical network, with the collaboration of experimented researchers in youth issues. And also to invite deciders to appreciate the advantage of such an outreach intervention. And I guess our take-home message is that we think that we are here to join a network which embraces our values and perspective. Our goal is really to emphasize the importance of including all youth, including homeless youth, which are represent the one who suffer social exclusion in our society, and also the ones for whom the system has not responded in giving timely access to critical care. And we propose this network as an example of a network that could change philosophies with a true collaboration to improve a real continuum of services with a youth-friendly, accessible services and outreach.
Thank you. Thanks very much. Merci. Now we have Steve, Mathias and Sarah Irving on transforming access to mental health services for adolescents and young adults.
Hello, I'm Steve Mathias. I'm a psychiatrist, child and adolescent psychiatrist, so I'm a clinician and the manager of the Inner City Youth Mental Health Program.
And I'm Sarah Irving. I work at BC Children's Hospital in a resource center as a forced youth in residence, so I'm a youth peer support worker, and I also work with homeless youth at a resource center in downtown Vancouver.
Sarah and I are both co-chairs of this proposal, along with three other co-chairs, two of whom are here today, Chris Richardson and Kelly Anderson. I began working in the field of child and adolescent psychiatry about 7 years ago, and I immediately was drawn to working with street homeless youth, working and building what is now called the Inner City Youth Mental Health Program. From that work, in the best example of Peter Principle, I was promoted and am now the regional head of infant, child, and youth mental health and addictions for all of the region of Vancouver Coastal Health. I have no idea how that happened, but basically I have to do something. And I think this is a great opportunity for us to find some synergy between what I'm working on in Vancouver and what I think really ails us nationally.
And I'm so excited to be part of this. Just as a youth with lived experience with mental health challenges, I also have lived experience in my family with my younger brother. And I work with a lot of youth who are having a lot of trouble accessing services right now. So it's very close to my heart, and I really want to be part of something to begin having a voice from the very beginning of this process.
So the groups that are part of our team doesn't surprise anyone, basically what most have explained so far, but of note we've had all six health authorities involved in our, sorry, that was really unfortunate. As well as various universities and researchers, 3 universities in particular, Simon Fraser University, UBC, and UVic. Of note, the BC representative for children and youth was involved in our initial meeting in April, and from that we were able to identify the gaps from her report that led to the TRAM proposal.
So basically everybody that needs to get it together was in the room.
So what's unique and transformational about our solution? Well, really, we propose to create communities of youth services, created by engaging a wide group of stakeholders to create a common agenda intent on addressing mental health concerns, including increased receptivity, accessibility, capacity, and sustainability. We really feel that this approach is different because from that group, we want to develop basically a shared measurement that everyone agrees to, not just the researchers, not just the clinicians, but the participants who are in the room. We feel that the funding that would come from the TRAM would support a backbone staff to support the collaboration, the implementation, and the research.
So really what we want is everybody that's trying to help us be in one room, so we don't have to tell our stories over and over and over again, so our families can be supported, so that we don't feel lost in the system. I want to be able to provide input from the beginning on what's not working and what's working for me.
Our idea will help identify youth who need services because our COIs will reflect the community needs and be informed not only by best practice, but by the youth and its families. COIs will link already existing points of contact, such as schools, community centers, youth organizations, and outreach services.
When I want to get help, I want to get it now. I want to know that the help is going to be relevant to who I am and where I grew up, regardless of my gender, my age, my sexual orientation, or even if I don't know who I am. I just want it to help me.
We feel that we can develop practice drivers based on our common agenda, which will lead to the creation of specific targets or measurements generated by the community. Physically, COIs will be readily identifiable venues where youth and families will access care and be linked into key youth services.
I want to know where to get help in my community. I want to know that that door is open for me and that that door is right around the corner. And sometimes I need that help to not be in my school.
Community engagement will improve the experience of seeking care, while peer support will normalize and destigmatize the experience. The COIs will include enhanced primary care and public health with fast-tracked access to mental health services via telehealth and shared care. And I must stress, all our partners are on board for this. COIs will not endeavor to serve a diagnosis. Rather, the COIs will serve the individual within the context of their community.
I don't want to be told that they don't understand what I have. I don't want to be told that I have to go and wait somewhere else. And I don't want to be told that I have to wait alone. I also want my family to be supported and not judged, because I am not an illness. I am a person.
So when we get to the last slide, what is the biggest challenge we still need to address?
What the heck? It is not this complicated. And that may be the challenge itself, is to overcome the fact that we are overcomplicating the issue. To me, youth need access to mental health services, and they need to know where to go to get help.
So as a last example, we want to talk about East Vancouver. And this is 30 seconds of your time, but East Vancouver is the poorest electorate in the country. East Vancouver has 12 schools. It has a mental health clinic. It has a community health resource. It has a public health clinic. It has addictions counseling. It has a work opportunity center. It also has multiple outreach centers, including an Aboriginal outreach center. Yet none of those are connected in any way, shape, or form.
A community waiting for a COIS is East Vancouver. The youth there have all of the services that we have discussed, and most of these services are within a 2-kilometer walk of each other, but they're not communicating. Yet, last summer, 20 Aboriginal youth made a suicide pact in that community, despite families, the community, the school, the existing youth services all expressing concern for these youth. The answer was to send them to the hospital. We can do better than this. And East Vancouver, along with several other communities, are hoping that this tram will transform the experience of their youth and families.
Thank you.
Thank you very much. Finally, we have transformational research in adolescent mental health and primary care, improving access to evidence-based practices for anxiety disorders, and it's Marie-Hélène Chomren. Thank you. Jean, you've joined us. All right.
Jean Grenier. Hi, Jean Grenier. I'm a psychologist and clinician researcher. I'm very happy to be here to represent the TRAM-PC, PC for Primary Care team. Like Steve, who just spoke, I'm a bit vulnerable to Freudian slips. Therefore, let Marie-Hélène do the talking, and I'll be switching the slides.
Okay, so I'm Marie-Hélène Chomren. I'm a family physician, so I'm representing primary care in mental health here. So I'll be presenting the team. We have a great team. We'll be quite quick. There's the works, like everybody has, the researchers, the policy makers, and the decision makers. So we have our 3 mentors, our 3 wise men, Jacques Bradwin, the Dean of Faculty of Medicine in Ottawa and anxiety disorder expert, Alain Lesage, who's a psychiatrist and also mostly involved with the shared care model and the stepped care model, his expertise, and William Hogg, who's also a primary care physician, researcher, and involved essentially in complex interventions in primary care. We have our expert clinicians in anxiety disorders. We have also our group of health economists, because I think it's important. The decision makers always want a business case, so we'll have to hand out a business case. We have our expert in self-management tools and decision aids. And a number of our young researchers, but really established researchers who are interested in health services, interprofessional collaboration, teamwork, also knowledge transfer and evidence-based practices. And our educational researcher, and also our IT computer science PhD, who's there to help us for all the management tools, etc. And we have our collaborators from Australia. We've been working for at least the last 10 years with them. We've been looking at, to very, very much envy, the transformational change that has happened in mental health in Australia, and so they're on board, as well as Martin Knapp in the UK, and also transformational change in the UK has been quite exceptional with the stepped care model. We have a number of knowledge users and also a number of collaborators. We have the communities on board, and we have communities ready to participate and work with us. Next. So what is the problem that we're trying to solve, that we're really interested in looking, is really anxiety disorders. And for us, anxiety disorders is really one of the most common mental disorders. It really represents a major public health concern, and also it has huge societal costs. We know that the age of onset is early on, early childhood and early adulthood, and there's a high prevalence in adolescence, and has really a major impact on their lives and their lifestyles. So why is our transformation unique? I think for us, primary care is key, and I think the WHO has been clear, and recently a paper from the European Mental Commission also stated that really primary care is central to mental health care. The majority of mental health issues are taken care of in primary care. So we really need to empower primary care. It needs to do better work in what it's doing, and this is really what we're looking into. So we plan to implement and evaluate youth-friendly, evidence-based practices in primary care, and we're really going to work with what is called the normalization process theory framework, which really is a tool and a framework to try and implement evidence-based practices so that they become routine in primary care. And this is really essential for us, that they become the standards of care, which is not presently what is happening. How are we going to help identify youth? And I think that if we do empower, and there's a lot of knowledge translation which is going to be made, that the identification will be made earlier, so we'll be able to identify much earlier our patients or the persons. And we know that AD is really treatable, and this really has to come out. People have to be informed that it is treatable. And we'll be also working closely with families, and I think in primary care we're used to working with the communities, working with the families, because this is essential. There's no way we can treat anybody, whether it's an elderly person or child, and in primary care also what the issue is that we have the continuum of the age. There is no age group. It's from the moment I have delivered my patient, and then I see the daughter and I see the grandmother. So they're all there for us. More care, I think if we use more youth-friendly access, more youth-friendly evidence-based practices, more youth-friendly tools, e-health, m-health, all those electronic strategies, I think we'll be able to access more of the youth. I think we also need to be more integrated in the care that we do, and that's really one of our goals. Will they get better care? Well, we do hope that by rolling out evidence-based practices, they will be getting better care at the right time. Well, our biggest challenges, well, we need the resources to do what we want to do, of course, and we need more youth engagement. We do have a youth panel on our team also, which I haven't mentioned because I've been talking to them lately, but they are there because I think it's actually essential. As somebody was saying, we need to know them and to be able to serve them better. I know recruiting primary care clinics is always an issue, and that's why we also need the resources, because most of the time, well, family physicians want to be somehow compensated for the time they will be giving. So I think, but we're all there. I mean, most of our team, there's a number of family physicians on board with us, so we have quite a lot of connections with the primary care. And I think it will be a challenge to implement and the evidence-based practices, but I think it's feasible. All right, thank you.
Thank you. Thank you so much. Marie-Hélène and Jean, thank you.